So a 70-year-old guy walks into my office, known obstructive sleep apnea, and he says to me, I'd really like to get this implant because I'm going to Europe next week and I don't want to take my CPAP machine. So this is a true story. So we know that there's an implant that takes care of obstructive sleep apnea, but there's a lot of misinformation or lack of knowledge, and so both professionally and in the public. So hopefully this talk will help clarify some of this. When I was thinking about what to call the talk, hypoglossal nerve stimulation, I thought, well, maybe I should be something flashy, shocking news. But then thought maybe something a little better, overcoming the resistance. Oh my goodness. But then I thought, how many electrical jokes could I make? So I settled on this electrical joke, current concepts. So I have to disclose I am a consultant for Inhale Medical, which will not affect this talk at all. So what are we going to talk about today? And today we're going to talk about obstructive sleep apnea, touch a little bit on CPAP. Why do we even talk about sleep surgery, since we do have CPAP? We'll talk about physical exam, surgical intervention, and then the main bulk of the talk will be about hypoglossal nerve stimulation, the who, the what, and the why. So let's talk about obstructive sleep apnea and CPAP. So obviously, treating obstructive sleep apnea is reversing the collapse. And CPAP is universally accepted as the first-line treatment. And CPAP is so desired that couples share CPAPs at night. I don't know if they wake up in the middle of the night and transfer over, but the problem is not everybody can use CPAP. So this is a study that we did with one of our former residents, Dr. Russell, now at Johns Hopkins. And what we did was we reviewed all Cleveland Clinic polysomnograms over a 2-month period in 2010. There was, I think, about 1,000 or 1,100 studies, and we selected the studies that had an AHI greater than 15 or an AHI 5 to 15 with sleepiness, which is the Epworth Sleepiness Scale score greater than 10. And then because we have the electronic medical record, we checked their charts 3 years later to see if they were still using CPAP. Did they get CPAP? What was going on? I won't go through the nitty gritty, but a couple of takeaway points. So 56% of everybody, of all the patients who met criteria, were not using CPAP 3 years later. I mean, think about that. That's an astounding number. 29% of patients who refused CPAP right off the bat were referred for further treatment. So that's less than a third of the people who were passed on for another therapy if they didn't want CPAP. And 40% of patients who were PAP intolerant were referred for further treatment. So that's the people who tried CPAP, were not successful. Only 4 out of 10 were passed on. So there's a lot of patients out there who need some sort of other therapy. And this was a few years ago, and CPAPs have improved, but there's still a large number of patients who still need therapy. So why surgery? This is a recent study from Stanford, Rob Capasso, and basically they compared soft tissue surgery with patients who were given a CPAP prescription. So this is the next step beyond our study. So just getting a prescription, they don't know who filled it or who didn't fill it. But basically, people who had soft tissue surgery had lower rates of cardiovascular, neurological, and endocrine complications. So there is some benefit to having surgery. And it's known that just most people don't use CPAP based on these studies. Well, I should refine that. Not most people, a large percentage of people have trouble with CPAP or don't want to use it or don't. So, physical exam, obviously people come in and we take a look at their general body habitus, nasal obstruction, adenoids, tonsils, palate, and tongue. And this has been our traditional way of taking care of obstructive sleep apnea. So BMI, that plays a big role. Patients with higher BMI are more likely to have obstructive sleep apnea. And the higher the BMI, the less likely successful treatment is going to be available to them. So we do take a look. I am looking at men who walk into my office and they're wearing a polo shirt, and if they have, it unbuttoned down to the lowest button and it's still choking their neck, I know, we're in big trouble. Definitely nasal obstruction plays a role. Nasal obstruction does not cause obstructive sleep apnea. It's thought to be a secondary actor. Certainly it can cause problems with adherence to CPAP just because of the airflow. We do look at the tonsils, palate, tongue, and then we also do an airway exam with the flexible scope. Please note that besides all of this, the sleep study is important. There are studies that show we are terrible relating physical exam with the possibility of having obstructive sleep apnea. We cannot predict who has obstructive sleep apnea just by physical exam. But we do try and predict who's going to be successful with surgery by physical exam. So let's talk a little bit about surgical intervention. So I will say again, CPAP is the first line of treatment, and surgery is for patients who do not tolerate CPAP. Now, interestingly enough, we have been doing the same surgery with some minor variations since the early 80s. In the early 80s, a surgery was brought over from Japan. It's a surgery for snoring. And this was adapted at Dr. Benniger's old institution, Henry Ford. That was the epicenter of surgical treatment for obstructive sleep apnea. And this is for patients who did not tolerate CPAP, but the surgery, as I will show you, has some limitations. We normally, prior to hypoglossal nerve stimulation entering the scene, would treat based on the perceived level of obstruction. If it was a nose, you'd fix their septum. If they had adenoids, which most adults don't, we would take out their adenoids. Uvulopalatal was the mainstay for the last 40 years. And then hypopharyngeal surgery, lingual tonsillectomy, base of tongue reduction, hyoid suspension. And, these have various levels of success, but we were always looking for something better because we know that this surgery that I'm about to show you was not overly successful in the majority of patients. This is a traditional uvulopalatal. Here you can see, it's upside down. This is not the surgeon's view, but we take out the tonsils, cut across the soft palate, just posterior to the maximum point of elevation, sew everything together, and you would have this to start, and over here, to finish. And back in the day when you saw this, you say, "Wow, that's a great result. Look at that. There's a mild arch to it. It's well healed, thin scar." From a surgical standpoint, it looks great. However, if you look at the results, this is a study out of China from 2019, and they looked beyond the immediate post-op period for patients who had uvulopalatal. And what they found was basically over time there was backslide, and we know this just from anecdotal evidence, but they measured that the surgical response rate decreased from 67% immediately after surgery to 44% at 3 years. So these are not great results, and that's why others were always looking for a way to do better sleep surgery. So let's talk about hypoglossal nerve stimulation. So this just came on the scene in 2014. That doesn't mean that all the work didn't span decades prior to that. Back in the 80s, they were doing hypoglossal nerve stimulation or trying to do these experiments on cats. And so it took a very, very long time to work up to what is now the only commercial implant available, which is Inspire. There are approximately 12,000 implants currently that are in patients. So we have a lot of opportunities to gather data. This is the, over on the left, this is the actual device that gets implanted in the upper chest. This is based on pacemaker technology from Medtronic. And over on the right, the top is the stimulation electrode. This is what we attach to the hypoglossal nerve. And the bottom is the sensing lead. This is what gets implanted in the intercostal space. And we'll talk more about that as the talk goes on. So what are the criteria? This is what everybody wants to know and nobody can remember unless you do this over and over and over again. And it changes every so often. So the first criteria is CPAP failure. What is CPAP failure? That's an interesting question. There is no discernible measure that is exactly CPAP failure. It is people who absolutely cannot imagine themselves using CPAP. It's people who are claustrophobic and can't wear CPAP. People who have tried CPAP just can't keep it on. People who are, allergic to the mask and their face breaks out. People who have significant aerophagia. They put on CPAP and they get bloated because of the pressure. And more that you can think of. But it is more of a subjective thought of what is CPAP failure. It's not truly objective. Age 18 and above, BMI 32 or less. Now this is a little bit variable. It's recommended, but it's not necessarily strict. If you're on Medicare, for example, you could have a BMI up to 35. There's another commercial insurance that is a BMI of 35 as well. Other insurances state a BMI of 32, but if you request ahead of time, you could possibly have some back and forth with the companies in order to get that approved. So this is a little bit of a fuzzy criteria. AHI, 15 to 65. But if you're on Medicare, it's open-ended. You can have as high as you want. There's no upper limit, which to me makes the most sense. Even if you don't cure somebody, we have to assume that there is some sort of linear relationship between severity of obstructive sleep apnea and severity of disease outcome. So anything that you can do to reduce it, even if maybe you don't get it down to normal levels, I think would be of benefit. And you have to have less than 25% central apnea. Central apnea, for those who don't know, is basically when your brain doesn't give the signal to your body to breathe, and so you don't have any respiratory effort, as opposed to obstructive sleep apnea where the effort is there, just that the airway is obstructed. So who can't get it? Drug-induced sleep endoscopy findings, and we'll cover that more in just a moment. Conditions that have neurological compromise and control of the upper airway that's compromised by this neuromuscular issue shouldn't have it. Patients who don't have the ability to operate the sleep remote, which turns it on. Patients who are pregnant or plan to become pregnant, I am not sure why that is, but they have that. And there are limitations to MRI scans. So if you need MRI scans of your body regularly, probably not a good choice because this will make that not possible. The early implant, which we had for 2 or 3 years, was not MRI compatible at all. The current implant is MRI compatible. If you want a 1.5 Tesla magnet MRI to take a picture of your head or your extremities. So you can get some MRIs, but you can't get it from neck, chest, abdomen, pelvis. You can get CAT scans, x-rays, ultrasounds, all of those other things. So relative contraindication is insomnia. So patients who have difficulty falling asleep, and I see patients in my office who tell me it takes them 2 or 3 hours to fall asleep. None of them are residents in our program, obviously, but there are people who just have significant difficulty falling asleep. So is this an absolute contraindication? No, but patients have a delay built in so that when we turn on the device at night, if it takes them 20 minutes to fall asleep, we can program the device to start working at 30 minutes so it doesn't come on while they're awake. If it takes you 2 hours to fall asleep, we don't have a delay available to us that long, so it's much harder. But because I want to bring you the latest information, just published this morning out of Cincinnati, there was a paper by Stacy Ishman who looked at veterans, a small number of veterans, some with comorbid obstructive sleep apnea and insomnia, and a significant number of them showed improvement in their insomnia when they used hypoglossal nerve stimulation. So you heard it here first. So, this is widely advertised, but there's a lot of patient and physician misconceptions, as I started the talk with. Many don't even know that it's actual surgery. So we have to have that conversation in the office to let them know. So where did this all come about? Well, this is the article. This is an otolaryngology article published in the New England Journal of Medicine. We don't see it that often. So this is in 2014. It was called the STAR trial. I had acronyms, so I have no idea what STAR stands for, but this is the hypoglossal nerve Inspire trial. And this is what led to the FDA approval. So here were their findings at that time. And I have to tell you that this was the original implant, and the surgical technique was not consistent throughout the entire trial. They found improvements in the way of isolating the hypoglossal nerve. So these findings are just a mixed bag, but at the initial findings, the AHI at baseline was 32 and went down to 15. So if you look at the median, that's quite significant, 29 to 9. The oxygen desaturation index, how many times a night how many times per hour you're desaturating. You can see that improved significantly from 29 to 14. The FOSQ, this is the functional outcome of sleep questionnaire. So going higher is better. So a very significant change from 14 to 17, excuse me. And the Epworth Sleepiness Scale score, this is a validated instrument that measures how sleepy you are. There's 8 questions. If you're sitting on a couch, watching TV, if you're reading a book, how likely are you to fall asleep? And that improved. Above 10 is pathologic, and it came down to 7. So this is the original implant procedure and resultant device in the body. So right here is the actual device, and then there's 2 leads that come off. One is the stimulation lead that goes on the hypoglossal nerve, and the other is a stimulation lead, which we placed a little more lateral than this, down near the anterior axillary line, where we placed this device in the intercostal space between the internal and external intercostal muscles. So before doing this, I really didn't think of the tongue and all of its different muscles, or the hypoglossal nerve and all of the different branches. I think most of us think of the tongue as a solid piece of meat, and here it's a solid piece of meat to be replaced by a thigh or a scapula or a forearm. But if you break it down, it is a collection of lots of different muscles doing different things, and you can see those here. But the most important, and I will show you on this slide, so here's the hypoglossal nerve. This is the main trunk at the arrow. So the early branches off of the hypoglossal nerve, which, you know, how many of us thought about these distal branches of the hypoglossal nerve when we were in anatomy, or if you're doing, you know, back in the old days, 12 to 7 anastomoses for facial paralysis. So this is the main trunk. The early branches are retrusors. They go to the retrusors, like the hyoglossus and the styoglossus muscle. These pull the tongue back. So obviously you don't want to stimulate those. As you get more distal, the nerve stimulates the protrusors, which is the genioglossus muscle, and C1 for cervical nerve going to the geniohyoid muscle. So this is something that protrudes the tongue, which sounds like you'd want to stimulate more than the retrusors. And right here where this arrow is obviously where you want to stimulate, because there's a natural break between those two groups of nerve fibers. So as we're working up for implantation, if it fulfills all the previously mentioned criteria, we have to do drug-induced sleep endoscopy. So this is a procedure that was already in use for sleep surgery, of, you know, controversial as to whether it improved outcomes for traditional basic tongue or uvulopalatopharyngoplasty, but it was out there. And this was used, and they found that there was a difference in outcome between anterior posterior collapse or concentric palatal collapse with this endoscopy. So what is the procedure for drug-induced sleep endoscopy? This is a flexible endoscopy while sedated and supine for the most part. We use propofol. We slowly increase the concentration, blood concentration of propofol to the point where they're asleep but spontaneously breathing. We're trying to duplicate sleep. We're looking for the sites of collapse for traditional surgery, whether it's palate or base of tongue or lateral walls of the oropharynx. But for Inspire, as part of the FDA approval, it's anterior and posterior collapse versus concentric collapse. Concentric collapse was found not to be successful as anterior posterior collapse, but believe it or not, this was only on about 8 patients, and so they cut them out so that they could get some improvement in their other patients and have a more dramatic success rate. Interestingly enough, earlier this year, this was published in the Sleep Journal, and what they found that, you know, in the early days, some of us were using, and I used dexmedetomidine because it was not as narrow of a therapeutic window as propofol. Because sometimes if you overshoot propofol, if you're not working with somebody you work with all the time, you can get obstruction right away, and then you can't see what you need to see. But this paper was interesting because what they found through machine learning is that dexmedetomidine-induced deep sleep sedation mimics stage 3 sleep. And stage 3 sleep is not associated with obstructive events, less likely to occur. REM sleep is your most likely stage of sleep to be associated with obstructive events. Stage 3, I mean, the muscles are supported. That's why people use dexmedetomidine, because they can have some sedation, but it doesn't destabilize the airway muscle. So this is probably not a good medication to use for DISE if you're having a conversation around the water cooler about what medication to use for DISE. So here's a video of DISE, and here we're going in the left nostril into the nasopharynx, and you can see the posterior pharyngeal wall. You can see the soft palate inferiorly, and you can see that this is a relatively flat surface of the superior aspect of the soft palate during sedation. And so this I would call anterior posterior collapse. Here's another DISE. And as we work our way to the nasopharynx, you can see this has a more circular appearance. It looks more like a sphincter than a flat surface. And so this would be somebody that we would not consider for implantation. Now, I have to tell you that not all DISE is black and white. You can't separate everybody into anterior posterior versus concentric. There's a lot of gray area, so there is judgment involved. There was I don't know that it ever got published, but there was a study presented at one of the international surgical sleep meetings where they looked at previously recorded DISE from around the country, and they had independent raters look at them, and there was not necessarily agreement on what was happening on DISE compared to what the original surgeon said, and that there were certainly people who were thought to have concentric collapse who had implants and were successful. So I don't know where this all fits in and whether we'll be doing DISE forever for this, but for now, these are the rules we have to go by, but it's definitely not black and white. I don't know who's watching online, but you know, if you're not used to surgery, there will be some surgical videos coming up. So this is how we start for the approach to the hypoglossal nerve. So under the inferior aspect of the mandible, the jawline, halfway between the hyoid and the mandible, about a ½ centimeter off midline, a 4 centimeter incision. When we set up for that surgery, we use the nerve monitor. So we are looking to separate out, when we stimulate the nerve, between the protrusors and the retrusors that I talked about earlier. So the protrusors are in the floor of the mouth, the genioglossus, and so we put the probe in the floor of the mouth. The retrusors, we are further back on the tongue, lateral aspect of the tongue, about 5 centimeters back from the tip. And so what we'll see is that when we're looking for the nerve, we can test it and separate out which branches we're including. Whoop. There we go. So this is under a microscope. It never looks like this. For those of you who operated with me, it's never this clean, but this is a great view. You can see the main trunk of the nerve right here. That's C1 at the bottom. They're stimulating C1, and you can see on the nerve monitor to the right, that is the blue probe, the protrusors. That's the main trunk of the nerve. And then they're reaching up top, and that is a retrusor. So there is a break point in the nerve. So this is the main trunk of the nerve. You can see perhaps this little tiny sliver here. That is the retrusor. So we have to make sure that we are working on this to separate it out from the branches up here. So when we're putting on the cuff, the stimulation cuff, we isolate that part of the nerve, and here's the cuff. There's some silastic, it's got a memory, we open it up. And then we can reach underneath the nerve, and you can see C1 trailing inferiorly, that little branch at the bottom. And then we grab and we pull it through. and boom, it's on. And you can see there's 3 different electrodes, which gives us different modes of programming available to us, because not all of those electrodes will stimulate with equal ability, and some can be changed from positive to negative, cathode to anode, and different electrical fields. So there's lots of options for programming afterwards. So I showed this before. We also make a pocket in the chest where we put the device, and go between the ribs, put the sensing lead that I showed you before. So that surgery is a ambulatory procedure. It takes between hour and a half to 2 hours to do. We follow up about a week afterwards for a post-op check, make sure that everything is healing well. Here at the Cleveland Clinic, it's truly a collaborative effort, and we co-manage these patients with the folks over in the sleep center. So about a month afterwards, they get activated, the device is turned on, and then it's adjusted to get to a therapeutic level. Initially, it was 2 months, where it was like right after surgery, you've got to have a sleep study to titrate it. Now I think it's much more lenient, so that's why it's 2 months-ish. It's adjusted to what the patient feels like they're sleeping better, and at some point, we get a titration polysomnogram to see where they are and test levels above and below where they are to see if this corrects the apnea. And then as time goes on, you can get home sleep tests, variable timing. It's not standardized unless you're in some sort of research protocol. This is how you turn it on at night. This is a remote control. You hit that green button, lay it over, and it turns on the device. There's a pause if you get up in the middle of the night to go to the bathroom, and then you can turn it off in the morning. So here you can see the effect. The red is bad for some reason, and blue is good. So you can see the collapse of the palate and the tongue base, palate above, tongue base below. And then with the therapy on, you can see it popping open with each breath. So the Inspire device is not giving stimulus all the time. It's giving a stimulation with every breath, and then it turns off. There are other devices that have not quite made it to market that have continuous stimulation, but this is definitely intermittent stimulation, which theoretically would lead to less fatigue. So here's an interesting study. It was always known that there were some patients who had cross innervation with the tongue, with the hypoglossal nerve. But here's a study from Maria Cerna in New York, a previous co-trainee with Dr. Hopkins in Cincinnati. But what she did was, instead of putting unilateral probes to test, since we're placing a unilateral stimulus, she put probes bilaterally on the tongue and the floor of the mouth. And about 39% of the patients had bilateral stimulation with unilateral implantation. And so you can see that the patients here who had bilateral genioglossus stimulation versus who had unilateral genioglossus stimulation, their results really weren't any different. So you can stimulate unilaterally and have unilateral innervation of the tongue, and your results will be the same as if you have bilateral stimulation, which is sort of an after-the-fact validation of a unilateral implant. So you don't necessarily have to have a bilateral implant. And you can see that the oxygenation improved similarly whether you had bilateral stimulation or unilateral stimulation. So, things, like all surgical endeavors, things don't always go perfectly. Some people get some tongue irritation from the tongue moving if they have sharp teeth. So some may benefit from a guard placed over the teeth, so make it smooth so the tongue doesn't rub against the teeth. Some people have stimulation intolerance, There's various strategies to adjust that. You could decrease the voltage. You can reconfigure those 3 electrodes. You can make it positive, negative, positive, which is the off the rack configuration. You can make it negative, negative, negative. You can turn some of them off. There's all sorts of ways that you can redo it. And a few years in, the Inspire folks came up with an algorithm. If the patient is having this problem, take these steps. Before, it was kind of like the Wild West. You sort of did whatever you thought was appropriate. But now there's a very measured pathway, and I think the results are improving because of this. And if patients aren't tolerating that stimulation, you have to acclimate them, and you may turn it so low that they barely feel it, and it could take 6 months to a year till they get up to the point where they can tolerate the stimulation. That's thankfully not the majority of patients, but it is a way to bring everybody on board. Infection. So about 1 to 2%. If it gets infected, you have to explant. The question is always, how much do you have to explant? And it depends where the infection is. This is a patient of mine who he was over a year, and his skin broke down over the stimulation lead in the neck. He had very bad skin. He had bad psoriasis. He was on one of the biologics for his psoriasis. I don't know if it affected it at all, but so I did have to explant just the stimulation wire, and I was able to leave in the pulse generator and the sensing lead, and we went back and I placed an opposite sided lead and tunneled it across back to his original implant site. You can get device failure. Sometimes the implanted pulse generator has electrical issues. Sometimes the leads are not inserted well. And sometimes you have problems with the sensor lead, which they think may be related to where we're grabbing it as we implant it. So here is a patient. This is a patient of mine who got one of the first or second improved devices, the 2nd generation device. And so when that came out, they really didn't give guidance of how it was different and how to insert the leads. So this is a working implant, and this implant is not working. So the patient came back to my office. I went to turn on the device because the surgery went great, and we were staring at each other like, well, what went wrong? So I got an X-ray, and you can see the working implant. These leads are through these little metal blocks right here. You can see a little piece sticking through, making great contact. In this one, you can see this lead is abutting it, but not through it. So I had to take this patient back and reinsert this lead and push this lead in a little bit further. And what can happen with the current device is that you can get air pistoning. There's no escape route for the air once it's so tight. Once you put the pin into the pulse generator, it builds up pressure. So now, instead of just our usual original guidance of, stick it in, tighten the little set screw, now you have to have 3 hands doing it. One person holding the device and pushing in and holding in the pin, and then a third hand to tighten the set screw. And I guess that air will eventually siphon out, but it makes it so it's in contact. Yes, Joe? Yes. Yeah. So it built up enough pressure to work it out, but it's never happened again. So this is a relatively recent patient who 19 months after implantation, they found that his device wasn't working properly. They were getting some weird waves. And for those of you who recognize this, this is a C-arm. So you may notice I've never talked about a C-arm during implantation. So this is a patient I had to go back on. And we replaced the pulse generator And you can see that up at the very, very top, and you can see the pins through. So it's working as it's designed up here. But it was then decided that the sensing lead, there was a problem. So when I went back to pull the sensing lead out, the end of the sensing lead was missing. So I was looking at just bare wire. So I had to go and fish between his ribs to find this. This is the metal end of the sensing lead that I showed you before. It's probably about 2 centimeters long. But the interesting thing is, I know it didn't happen as I pulled it out because that was in its own separate capsule. So it had healed in, had a capsule around it, and we were able eventually to find it. I was playing thoracic surgeon for a while, but we were able to find it, and I was able to re-implant a new lead, and everything's working fine. So, as I showed you earlier about uvulopalatal-pharyngoplasty, durability. So 3 years down the road, there was significant decrease in success rate. So, so this is a group from the original STAR trial. 5 years later, what happened to those patients that they implanted? So, to me, this is a very exciting group of charts. Why is it exciting? It's exciting because if you look on the x-axis, that's time. That's 5 years. And you can see all of the changes that have occurred are durable. And that is really, really exciting for sleep surgery. So if you look at the Epworth Sleepiness Scale score, remains low. AHI remains low. The FOSQ, so the subjective bits about what happens to their life after implantation, remains elevated. And I'm going to magnify this other chart. So if you look at the responder rate, so this blue line, so how many people we define surgical success, that's a whole other lecture about what surgical success, but if you reduce the AHI by 50% and end up less than 20, you can see at a year and beyond, it even gets better a little bit with continued use. And the FOSQ remains elevated, and the Epworth Sleepiness Score response rate. So this is great. I mean, this is truly validating the concept that this is an excellent treatment. So this is, we love all those other things. This is what the patient and their bed partner are interested in, snoring. So if you look initially, 30% of bed partners had left the room because of the snoring. Another 24% very intense snoring, and then loud, and only 6% had no, 11% had soft snoring. But at 60 months, if you look, the 90% of patients had either no snoring or soft snoring, which is something that both the patient and their bed partner is interested in. And in fact, the delay that I talked about, the spouses or significant others who are sharing the bed tell me they know when it kicks on. They know that the patient falls asleep, they're snoring, and then all of a sudden the thing comes on and their snoring goes down, so that they have external evidence that the device is working. So the ADHERE Registry, again, unfortunately, my dislike of acronyms, I don't know what ADHERE stands for, or I did at one time but don't remember it. This is basically a multinational registry of patients who have been implanted. We are part of that registry, and we're looking at efficacy. This was published in 2019. There were 1,000 patients in the registry from 2016 to 2019. About 300, between 300 and 400 of them had at least a 1-year follow-up, and that's what this paper is presenting. And so This is the real world. This isn't the STAR trial. This is people who have been implanted all over the world. And you can see that the median AHI went from 32.8 down to 9.5 at 12 months. So this is pretty tremendous. And if you look at who's responding, what we defined as the responder rate, with the AHI less than 20 and a decrease of 50%, 46% were less than 5 in their AHI. That's fantastic. Less than 10, 68%. And if we look at less than 15, which is really the category of mild obstructive sleep apnea, 80% were responders. So that's pretty fantastic. And then we can see the median Epworth Sleepiness Scale score from 11 down to 6. So they're less tired during the day. There was a difference, a little bit of a difference between males and females. And you can see that the women decreased from 34 to 10, and the men decreased from 36 to 15. So there was a slight improvement advantage for the women in the study. What about that, besides the Epworth Sleepiness Scale score, what about fatigue? So this is a study that looked at a maintenance of wakefulness test after implantation. I won't go into all the details of what a maintenance of wakefulness test is, but basically you go into a dim room for a daytime and they see if you fall asleep. Various times with different trials. And you can see the pre and post implant that their time of wakefulness improved. So here's some more objective evidence, at least in this small study. Are there other predictors besides DISE? So beyond DISE, what could you look at? This is a study from Raj Dedhia, who was at Emory, he's now at Penn. And what they looked at was what was the pressure level of the CPAP titration study, and did that affect outcome? And they found that if you had a pressure on your CPAP of 8 or less, you were more likely to be successful. I'm not sure that would inform us of any predictive value of people above. Would you not implant them? No, of course we would implant them, but this just suggests that a lower pressure means that you have less mass, and then maybe the stimulation would be easier to accomplish at the current levels. Here's a study that we were a part of as well. If you had previous surgery, if you had a previous uvulopalatal or a maxillomandibular advancement, did that affect the outcome? And the answer is no. There was no difference whether you were surgery naive or whether you were a previous surgical patient. Outcomes were the same. And so this is an interesting one. I recently listened to a podcast from the American Academy of Sleep Medicine about what do we really measure for sleep apnea? And the conclusion was apnea-hypopnea index, was not a great measure. Maybe there's other things that are really, really more important. And one of the things they mentioned was maybe heart rate variability. So if you look at an EKG, is the R to R difference, is that consistent or is it variable? The variability suggests that there's some sort of autonomic dysfunction going on, perhaps from your sleep apnea. And so what they found here was they looked at people from the STAR trial, that original New England Journal group, and the R to R variability improved. And all of these things that we measure are substitutes for, does this make them live longer? Do they have less strokes? Do they have less abnormal heart rhythms, coronary artery disease? But we don't have the ability to, at this point, especially in surgical studies, to have a huge group of implanted patients, a huge group of controls, and then just watch them for the next 10, 20, 30 years. So we're using substitutes, and this paper is a substitute and is suggestive that there's some improvement in autonomic function. So I'll put future in quotation marks here. Here's a paper that I and Dr. Maleka did. We went down to the anatomy lab because we were always thinking, hey, wouldn't it be great if you could just do 2 incisions for this implant? Could you put the sensing lead and the pulse generator in the same place? And so we went down to the anatomy lab and we looked and we found that the internal and external intercostals high up in the chest are paper thin. We could not, in the cadaver, get between the internal and external intercostals without being on the pleura. So we put out there, higher risk for complications if we really go up and do that. But of course, not that much longer, the Inspire folks announced the FDA approval of the 2-incision implant procedure in the same area that we did our study. And I will say, I'll show you. So the idea is to go under the pec. You just separate the fibers, go through the pectoralis major. There's a little fatty layer underneath, and then you put it between the internal and external intercostal of the between the second and third rib. This diagram makes it look like you're having a slab of bacon above and below. It does not look like that. And so here's a picture of the pec major. This is lateral, this is medial, this is superior, and this is inferior. And so you just sort of separate the fascicles here, the bundles. And when you go through that fatty layer that I showed you before, you see muscles that look a little bit like strapping tape. You see that glistening tape. That's the external intercostal. And you can see here's the external intercostal, and here is the internal intercostal. And they go at right angles to each other. And they are very, very thin. And I have to say that in a live person, I think there's 2 extra microns that we didn't see in a cadaver, because this is vital tissue, it's alive. And so you can just lift up that little flap and you can put in the sensing lead right there. And so that saves you a 3rd incision. Now, you have to be very careful. You have to be very delicate. I did read on an online blog, for people starting to do this, that one person said, oh, their first one, they got a tension pneumothorax from placing this here. So you have to be really, really delicate and careful and be aware of where you are. So it's not without risk. What about a wish list going forward? So our wish list already a 2-incision implant. I think an automatic on and off. So those patients with insomnia wouldn't have to worry about a built-in delay. If the device was able to sense breathing patterns, for example, and turned on and off when the patient was going to sleep, then that insomnia issue really would not be an issue. Remote programming, just like other devices like your CPAP machine, if you want to change the pressure, the medical supply companies can just do it from their office. They don't have to bring the machine in anymore. So if we were able to remotely program the device, then we could take care of patients all over the country and readjust things at a distance. An integrated sensor where you didn't have to implant that lead would be great, and they say they're working on that, so it could be a few years down the road, but that would make it much better. And if you could have some sort of sense of success right from the device, if you wear a CPAP machine, it tells you what the AHI is, gives you a ballpark. Are you successful on your CPAP machine? And if you could get that from the Inspire device, that would be great as well. There are some alternative devices in the works. This is a device from a company called Nyxoah. It's called the BLAST trial. I have no idea what that means. It fits into my acronym bucket of unknown acronyms. But this is the device. It's a bilateral device. And you can see over on the left that this is implanted in the anterior neck, and there's a paddle that is not specifically attached to nerve branches, but in the area of the nerve branches. And this is bilateral. At night, you put on a little sticker, and then this part here is the power, and this transmits the signal to the stimulation. So basically you're wearing a little hockey puck that's held in place with a big Band-Aid at night. And you can see here that they went from 23 to 13 baseline to 6 months. We don't know at this point what the responder rate was. We don't know what the explant rate is or comfort, but this is something that's in the works as a competitor. And I have to say, we're so early, like what we're doing is probably like the first iPhone. It's really great when you have it, but 10, 20 years from now, I think it'll be much, much more sophisticated. So here's a future direction. This was published in Chest of this year from David Kent down at Vanderbilt. And what they did, this is transcutaneous, this is not really an implant. They transcutaneously stimulated both the hypoglossal nerve and the ansa cervicalis. And they noted during sedated sleep that there was much more airflow when both nerves were stimulated. And this is a diagram, ansa cervicalis, and you can see there's some improvement, but if you stimulate both the ansa cervicalis and the hypoglossal nerve, there's significant improvement. And this is based on work from, I know you all read the Journal of Applied Physiology on the weekends, but this is perhaps a future direction in that maybe it's not one nerve that we need to stimulate, maybe it's two, or maybe it's more, that we could even bring it to a higher rate of success. So takeaways here, we always use CPAP as a first-line therapy. Hypoglossal nerve stimulation is another tool for treating sleep apnea. And I really think this is the future. The Cleveland Clinic says the future of healthcare since 1921. Well, I think hypoglossal nerve stimulation is the future of sleep apnea healthcare. I think this is where all the work is going to be over the next few decades. Here at Cleveland Clinic, truly multidisciplinary care. We share between us and the Sleep Center. And it does make economic sense, although this is an expensive device, that it is overall successful in reducing, if it's successful as expected, in reducing events like stroke or heart attack or recurrent atrial fibrillation. The cost is well worth it.